Time. Good afternoon, everyone. I hope you enjoyed your break. 2 more sessions to go, and then don't forget we have a reception after that. So our next speaker is Dr. Dante Paredes. Dr. Paredes is an assistant professor in the Department of Family Medicine and the Department of Osteopathic Medicine at UNT TCOM. He works in the HSC Health Central Family Medicine Clinic with a clinical focus on reversing diabetes, obesity, and generalized anxiety disorder. In addition, he teaches clinical nutrition for TCOM Family Medicine Core Clerkship. He is core faculty for the Medical City of Fort Worth Family Medicine and Osteopathic Neuromuscular Medicine residencies. Please welcome Dr. Paredes.
So this is where I turn this on. All right, just want to make sure I turn the thing on. Everybody can hear me? This is registering correctly? Awesome. All right, so yeah, 2 lectures left, guys. Then we're good. So today we're going to talk about the diagnosis and treatment of non-alcoholic fatty liver disease. There is an alternate name, metabolic liver disease. There's an ambiguity there. I can get into that later if you wanted the questions, but non-alcoholic fatty liver disease is going to be the focus for this discussion. The idea is we're going to talk about clinical relevance. We're going to talk a little bit about pathogenesis. For those who are afraid of biochemistry, I don't apologize. We'll have fun with it. There's like 1 histo slide, like 1, only 1, I promise. And then we're going to go into how to treat this thing. The cool thing about this is a TOMA conference. It's a bunch of DOs, right? Okay, cool. There's this idea that the medicine's useful, but can only take you so far. What I like about studying and treating this particular systemic disease, this particular GI pathology, is that it's one of the things that is profoundly affected by behavioral things, such that osteopathic philosophy we like to talk about kind of shines in this specific problem. That's for 2 reasons. 1, there's really no good med for this, and then 2, it is so locked into behavior that the treatment of the liver, the evaluation of a liver well done, is a good way to get an index onto how somebody behaves kind of in a holistic fashion. This is like the organ that lets you see into their life. Does that make sense? Excellent. Let's have fun with that. Let's talk about clinical relevance first. I don't like talking about things that don't matter, so I want to make sure you guys understand how prevalent this disease process is. I'm going to look at this slide a lot because it just makes sense with my body positioning. By the way, there's slides over here too, for those who don't know. The big thing to take note of is that it is highly prevalent and the prevalence is increasing. Why is it increasing? Is because it seems to be tied very closely to obesity. The metabolic syndrome diagnosis that we all chase, the obesity with the hypertension, the hyperlipidemia, the diabetes, plays with this. What ends up happening is the prevalence is about 38% in the general population. That being said, if you extract the diabetic population and focus on just them, the prevalence goes up to about 80%. That's 80% of diabetes folk. And I didn't memorize the statistic for how many folks have diabetes this year, but the number keeps going up. And if you can extract 80% of whatever that number is, that's a lot of people with livers. And the problem is, okay, so fine, why do I care about this fatty liver thing? Why not just treat this like diabetes or obesity? What is the specific contribution of calling this its own disease process? It's because 20% of folks with fatty liver, right, will end up developing inflammation and fibrosis, such that that fatty liver becomes something called NASH. That's non-alcoholic steatohepatitis, right? And the question is, okay, why does that matter? It turns out a percentage of those folks, so NAFLD, that's the non-alcoholic fatty liver disease, will progress to NASH, that's non-alcoholic steatohepatitis, and among that population, a subset will develop cirrhosis. And I mean, you're all doctors and hopefully med students here, so cirrhosis, you guys know what cirrhosis is. The cool thing about that is, again, it's tied to things that we can control for. We know that the Western eating pattern is notorious for inducing this state as an independent risk factor. Forget about the macronutrients, the micronutrients, the diet, the whatever. Something about the Western eating pattern wholesale seems to drive this problem, which is good because, hey, that's a thing we can recognize. We all know what McDonald's looks like at this point. I can say brand names, right? Cool. Burger King. Nobody's going to come after me? All right, just making sure. All right, that being said, the Western eating pattern is notorious for several features. It's highly processed. There's a saturated fat component. It's meat heavy. And I want to bring some attention to the meat thing because there's a lot of different diet camps out there, right? We have the keto side, we have the low carb, the plant-based whole food side, we have the calories in, calories out thing, the fasting thing, and all that stuff in between. Before getting too deep into the Western idea, I should just put a quick side. It should be asked why meat matters, because we know that meat seems to have an effect on this, right? But the question is, what is so special about meat? And it looks like there's a couple of different things. One, meat is highly anabolic. Skipping all the biochem, just meat is highly anabolic, and that's not necessarily a bad thing. However, when you have a pathology of overgrowth, of overnutrition, of oversaturation, we'll call it a disease of surplus, that anabolic signal could be a problem. And turns out Westerners are very good at developing a surplus for reasons that goes outside of food even, but you understand me. The idea is that the meat component, even though it's not the only one, will matter. I kind of want to address that later on. I just want to allude to that. I'm aware that meat could be a problem, especially when I start talking about the treatment side of this stuff. A large amount of people with NAFLD will be okay, but a subsection will develop NASH, and among that subsection, some will develop cirrhosis. It turns out that right now, fatty liver is the fastest growing contributor to why people get cirrhosis, right? We're getting good at the infectious disease part. How many people are actively treating hepatitis C a lot nowadays? Or hepatitis B, or hepatitis A, or even, you know what I mean? We know how to wash our hands, we know not to touch our butt, we have vaccines, and we know how to behave right, to some degree, right? So what ends up happening is the infectious disease burden for livers are going down. What ends up happening is what's left is the lifestyle stuff. That's big, because that means that, hey, if we can hit that, then we protect a lot of livers. All we have left to worry about is cancer, I guess. But even that kind of fits into this picture. The slide I'm showing you just outlines a little bit about why cirrhosis does matter. It's kind of preaching to the choir, but I want you to focus on this idea of ascites, of hyponatremia, of the hepatorenal syndrome, of the kidneys beginning to fail, and this idea that as the liver fails, you are easier to infect, which is bad for reasons, okay? Outside of just the liver, right? Outside of infectious disease, when your liver doesn't work, okay, you are twice as likely to have some sort of cardiac event. So if the absolute risk is 5, that means now it is 10. Just want to put that quick plug in, especially because I know we have a couple of med students of mine here. I see both of you. Hi. Absolute versus relative risk, right? The absolute risk is the chance that this will happen wholesale versus the relative risk is the change in magnitude of that change, right? So absolute risk of this is whatever it is, this will double that, double. The chance of dying from a cardiac event goes up by 3, so it's triple, okay? So we care a lot about heart disease in this country. So if you're telling me that this one thing will cut that risk in half and the chance of dying of it by 1/3, that captures my interest. Again, why does this matter? It matters because I care about hearts. All right. Quick slide here. Take a quick look at it. This is a good schematic of how the liver connects into cardiovascular disease. The big thing to connect here is that when the liver doesn't work right, your cholesterol metabolism, your lipid metabolism, your ability to recruit and regulate inflammation goes haywire. Sounds about right? More or less? Cool. I know some people in the audience, so I'm kind of looking at them periodically, just to be clear. The other thing that happens, the other thing that ends up happening is as the liver loses the ability to regulate that inflammation, you have to remember the anatomy of this. The liver connects to the heart via that IVC, that portal vein pours right in, blah, blah, blah. The inflammatory burden that goes into the liver washes out into the heart, and it turns out the worsening of liver path will end up burning the heart. What does it mean to burn the heart? The right atrium is right there. And when you cause significant problems to that, you end up developing potentially arrhythmias. There's a connection, meaningfully so, between liver health onto eventual cardiac arrhythmias, independent of cardiac disease itself, which is, I didn't know that until I was doing the lit review for this the first time I wrote it. All right, we're all keeping up so far? You understand why this matters? Awesome, just making sure. Because you should always ask, why the heck does this matter? Am I teaching you something that's useful versus just, I don't know, fun for academia's sake? This one, for me, it's a large effect size to benefit patients if we hit this right. So let's talk about how this happens. Let's start with metabolic syndrome. This is not a lecture focused on that disease process, so just a quick show of hands. Who here is not familiar with that term? If anybody. It's okay if you're not. Awesome. I'm going to cut to the chase then. It looks like the thing that makes metabolic syndrome itself so much of a problem isn't the fat itself or the insulin resistance per se, it's the visceral fat deposition into the abdomen, right? And you should be like, okay, what does visceral fat mean? It means fat deposition into the wrong organs, right? Fat goes into the sub-Q, we're happy, we like it. You might not like how you look, but it's where it belongs, it's not going to hurt you, minus orthopedically, because knees and weight bearing. However, if it goes into the kidney, How well can your kidney function if there's a bunch of fat in the way of that of the nephron, right? Think about the hepatocyte. How well can a hepatocyte function if there's so much fat in the liver parenchyma that it displaces the blood drainage and flow, right? What ends up happening is when you have visceral fat deposition into organs that are not designed to hold that kind of fat, it disrupts the blood flow. That's actually really cool. I didn't know that until a literature review of this. Basically what ends up happening is we know that when you have visceral fat deposition, you're going to cause meaningful inflammation, right? And then the question I always asked myself was, why does fat here cause inflammation, but fat there does not? And it turns out it's about what the drainage can do. We talk about lymphatic, we talk about arterial things, right? Talk about all that good osteopathic idea. What ends up happening is your organs like the liver, the kidney, and so on and so forth, they're not designed to hold that much fat. If fat goes there, that means it has to displace something meaningful. What ends up happening is they cannot oxygenate effectively. Turns out that's the mediating factor, which was really, really cool to find out. And what ends up happening is when you deprive a system of oxygen, it tends to get angry. Formally speaking, it'll apoptose, it'll inflame, it'll necrose, all that type of stuff will happen. Hey, that's the next slide. This is making sense so far? Cool. For the record, I'm not caffeinated. So what ends up happening is as you lose hepatocytes, you lose functional capacity. As you lose functional capacity, you lose the ability to do the job that the dang thing was supposed to do. And as the thing is no longer able to do its job effectively, now it begins to get inflamed because it's overworked and underpaid without enough rest. Cool. This is the cascade that leads to cell death. This is more for my students. This lecture is modified from a version I give over at UNT, by the way. That's why you see some of these deeper into the biochem sides. This is a tie-in to a lot of what I teach my students in their preclinical years as well. Inflammation. You guys should know this part. The critical piece here, there is actually some stuff that's relevant for y'all. The inflammation is mediated by something called a Kupffer cell. I'm going to say it again one more time slow. Kupffer cell. Keep that in your mind as we go about these slides. All right? What ends up happening, again, fatty liver to NASH to fibrosis. Okay, fibrosis means scarring. That's loss of functional tissue, and you replace it with something as filler. And when you have enough fibrosis, eventually you have cirrhosis. And once you're at cirrhosis, the question is, are you compensated or not? And compensated cirrhosis, you can handle that. I have patients with compensated cirrhosis. They do those stuff, they get to live, they're all right. But when you're uncompensated, that's just hell. And you can get them back to some degree, but it's a lot of burden to take care of those folks. You want to keep them from ever getting there. Because technically, what's the cure for cirrhosis? You give them a new liver. That means they have to be on the transplant list, which means there needs to be a liver available. But it also means that they need to be able to handle the new liver. And if I just told you with that liver cirrhosis and everything like that, there's such a big infection risk, how good can they really handle that process? It's a high burden scenario. Are we good so far? So pathogenesis, fat deposition, anoxic injury at the level of the hepatocyte, apoptosis and inflammation, necrosis, loss of function, replaced with scar tissue, and when you lose enough tissue, you end up with cirrhosis, which you all recognize by now. We're good? Awesome. Next slide. Let's talk about how to diagnose this. Okay, now this is the part that's more clinically relevant for my clinicians as opposed to my med students, you two. Hi. All right, so we have a small treatment pathway. We have a small algorithm to look at, okay? The idea is you start with the presence of chronically abnormal liver enzymes, okay? If the ALT and the AST are off, start thinking about that, okay? Doesn't mean it's this, because we can have other problems, but start there. Go, hey, something's wrong. What are the risk factors, right? Are clinical risks present? If yes, okay. Are ultrasound features present? That implies we're going to get an ultrasound. We're going to get an ultrasound, by the way. And if you look at this pathway, right, I'm not going to dissect the whole thing with you, but really the key decision-making feature here is, do you biopsy or do you do lifestyle stuff? Right? Look at the endpoints. It's biopsy or lifestyle. So let's talk about how to make that differentiation. So when are liver enzymes elevated? Okay. How many of y'all use a Quest lab routinely? LabCorp. Something else, because I'm still new here. I don't know what companies are around. What do you use? Nice. I just met those guys. Cool. All right, so we have 3. Your labs typically will take the ALT and AST. There isn't like a set threshold for when it's abnormal. I don't know if you guys knew that. The way you determine normal or abnormal on an ALT and an AST is based on a standardized population. So you normalize to a group, And if you're one standard deviation above that that mark, that's when we call it abnormal by at least by Quest and LabCorp indices. So, right, so like if everybody's ALT, just making up a number, was 300, you don't want that, by the way. Right? But if everybody had 300, guess what? That's normal now. Does that make sense? Good. So we need to differentiate what's normal versus what is acceptable. I'll make that word for this context, right? What is normal, as in what is in the population, versus what's the threshold for saying something ain't working right. And it turns out that threshold for non-diabetic men and women is about 29 to 30, call it 30 for men, and about 19 to 25 for women. That seems to be size dependent more than anything else. So like if you have a particularly like tall woman or a particularly short man, the indices move a little bit, but basically call it 30 for the sake of discussion, just to make things simple, because memorizing 2 sets is hard for me. So 30. If the ALT is north of 30, you at least start to wonder. Now, honest question, prior to hearing that, how many of y'all would bat an eye to an ALT of 35? Minus my people who treat liver disease routinely. You two don't count. Does that make sense? It's normal by the indices, and it's below the threshold for things like viral hepatitis, right? What's the threshold for I don't know, when do we care to say that it's fulminant hepatitis? Think about those numbers. That's like 2 orders of magnitude, that's times 100, bigger than this. Versus what if we're talking about alcoholic, as an alcohol-induced hepatitis? That's in the hundreds typically, right? So this range is much lower because it's a different pathophys. Call it 30. North of 30, you say, hey, I want to at least pay attention. With type 2 diabetes, that threshold goes down a little bit, okay? We look at it north of 27. Now that's like 3 points. Who cares about 3 points? You know what I mean? But you want to get that idea. The fact that they have diabetes means that the threshold got lower. And if you think about what diabetes does as an inflammatory agent, that kind of makes sense, right? Good. All right. For those who don't remember, these are the different liver enzymes. I'm going to focus on the ALT and the AST because the ratio does matter. I want you guys to take this particular point home. The ALT is a very good indices of what your liver specifically is up to. It will tell you about other things, but for the sake of this discussion, it's your liver guy. The AST, on the other hand, tells you not just about liver, but also about skeletal muscle. Does that make sense? And that the reason that's useful is because if the ALT is raised greater than the AST, that tells you that whatever the heck is going on localizes better to the liver. Versus if the AST and ALT are elevated together, or God forbid the AST is elevated beyond the ALT, that tells you that whatever's going on is more systemic. Either it's a late phase phenomenon, as in NASH, or it's a different disease process, look somewhere else. Does that make sense to everybody? Any questions about that so far? Lovely. Good. The ALP for this discussion is interesting. It doesn't matter for the sake of NAFLD per se, but you have to remember the ALP and the GGT will inform you if this is from other things. Don't go hunting for NAFLD when there's a gallstone in front of you. Does this make sense? Good. Very good. Risk factors, basically metabolic syndrome. And y'all said you guys know what it is, so I'm just going to list it off real quick. If you are obese, if you have elevated triglycerides, that's trigs above 150. If your HDL is low, that actual range depends on your gender. Same thing if your blood pressure is elevated, or if you have dysglycemia. You put that all together and you start to say, hey, this guy probably has NAFLD. Okay. And then the question is, how do you confirm that? Because you can suspect something and start doing all this fancy stuff, but you want to know that what you're about to put your patient through is worth it. That's really what it is. Don't waste their time and their effort with something that isn't there. So you go, okay, look, Mr. Guy, I know you seem to be healthy. Your hemoglobin A1C is good. Your CMP looks beautiful. Your fasting insulin's great, but this ALT is weird, man. It's like 40. What's up with that? Do you drink? And he goes, no, I don't drink. And I'm like, okay, let's do something about that. What you do. Who here has an ultrasound in their clinic? Cool. Us too, for the record. There's a thing, so if you don't have an ultrasound, refer out, send it out. Get a quick right upper quadrant ultrasound, they'll image the liver, the gallbladder, the pancreas, and I think they'll capture a little bit of like random GI stuff, and they'll report back to you. But for those who have the technology, like I like to use the butterfly ultrasound because I can keep it in my pocket, you know what I mean? Scan that liver. Because it takes all of the next slide to know what a fatty liver looks like. And if you see that elevated ALT, and the ALT is greater than the AST, and the liver's fatty, you get to go, hey, yeah, fatty liver, let's do something about it. Does that make sense? Lovely. This is a comparison view. So if you look at the picture on the left, or screen left, the liver and the kidney look more or less the same as far as their echogenicity, right? It's the same rough kind of gray. And just as importantly, if you look at the liver parenchyma, the liver structure, you see portal veins. That is a good liver. Everybody stare at that picture, whichever side you're looking at. That is a good liver. Bravo to that human. If you look at the one to the right, notice that the liver is brighter than the kidney now. Okay? Brighter than the kidney. And notice the absence of portal veins. That's the key feature here. Because I argued with some radiologists, like, when is this normal? Because there is a normal bound. You're allowed to be a little bit brighter. But if you're brighter and there's an absence of portal veins, we know that that's pressure from the fat accumulation, kind of going back to that inflammatory anoxic component. So take a look at those. Boom, boom. How long will it take you to look at that, to be able to grab an ultrasound, slap it on somebody, squirt some gel, and say, oh, got it, I can see it too. It's not that hard. You put it right here. This is focal fat. Focal fat in the liver is weird. You want to work it up further. That's the reason I put this slide here. It could still be fatty liver, but it's weird to localize in such a way for a systemic illness. This is a CT image of the same thing. So whereas I like to use the ultrasound in my clinic because it's right there, it's good to know that, let's say you're ordering an abdominal CT for some other reason and you incidentally catch this. Congratulations, now your eyes can see it. Notice the attenuation for the liver compared to the spleen on the left image. The liver is brighter than the spleen. Congratulations. However, if you go to the image on the right, the liver is darker than the spleen. That's the problematic one. Notice that this is flipped from the ultrasound, so it's modality dependent. The gold standard, okay, the gold standard image is going to be the MRI. Now, I'll tell you right now, the MRI is a lot more complicated. I just want you to know that it is the gold standard. The reason it's more complicated is because you don't just look at the image. You have to manipulate it in phase and out of phase. Do I have any radiologists in the room? Yes? Can you, microphones, never mind, sorry. I was about to ask you a question you understand me. Basically, you get a GRE image of the region, and depending on how you manipulate it, you'll see the fat or you'll not see fat. Without going into too much of the detail about that, just know that that's a thing. It's not just a simple matter of looking at it. You got to do some tech stuff. MRIs are really cool. They're like my favorite modality, by the way. But take a look at the image. Check out the darkening. Boom. If the guy's looking at this side, check out the darkening. Boom. Alrighty. So you see the elevation in the ALT. You know the ALT is bigger than the AST, right? You know that the liver is fatty based on whatever imaging modality you used. Now you go. So the question is, why would you biopsy? Because for those who know the work, one, the algorithm had biopsy everywhere, and two, the way to confirm this diagnosis isn't just to look at it. Even if the gold standard is the MRI, you still got to biopsy the dang thing. But do you really? When would you biopsy? You do it if you think this is not NAFLD, right? You do this workup and you say, hey, that doesn't look right. There's a mass there. There's something weird there. Or these labs don't make sense. The AST is greater than the ALT, which implies that this is a different process, or there's a different profile in the risk factors. Give me somebody perfectly, like A1C is 4.9. The insulin is like 2 or something. You know what I mean? Triglycerides, the HDL is like negative, whatever. They clearly don't have metabolic disease and everything's boring. How the hell did they get this? Maybe you start going, maybe I should biopsy this. Here are the criteria. AST is greater than ALT. Hypoalbuminemia, because that implies that the liver is no longer working correctly. And thrombocytopenia, because again, these are signs that the liver is not up to snuff. Something is wrong now. Good. I appreciate you taking a picture. That implies that I did something right with that slide. Good, good, good. That implies that for your liver patients, you should be following CMPs and CBCs. I don't like ordering labs for no reason. I try to get away with a BMP when I can. I get a lot of CMPs. It's because I look at a lot of livers. Good. You take the platelets, the albumin, you take the ALT, you put it into a score. You can get this on MD Calc, and the score will tell you what to do. If the fibrosis score is above a certain threshold, I have the indices here, it is likely that they have clinically relevant fibrosis. That's an important detail, because honestly, I don't know the distribution of all the docs here, but I'm a primary care doc, or at least I try to be. And what I do is I want to keep things simple as much as possible, but I need to know when to pull the trigger to grab a friend. So what ends up happening is once your F score goes past 2, I phone a friend. F0, F1, as in like if the liver fibrosis score is minimal, I'll handle this in-house, see if I can fix it and move on. But if it's above 2, I'm going to say, look man, I can probably handle this, but I'm phoning a friend, have you met my GI buddy? Or really my hepatologist, because GI and hepatology aren't the same thing. All right, quick check. We have 20 minutes left. We actually broke this into clean thirds. That's kind of cool. Any questions so far, either from the online or from you guys? It's okay if there's not. I'll keep going. Let's keep going. All right, so treatment side. Let's have fun with this one. I'm going to show these guys some love. I've been looking at you guys. Hi, everybody. The overall strategy, okay? We're going to call NAFLD, specifically non-alcoholic fatty liver disease, the liver manifestation of metabolic syndrome, just to simplify the model, okay? Because this is a liver-focused phenomenon for metabolic disease, we're going to treat this very similar to metabolic disease, okay? It's going to tweak a little bit because of the kind of disease we're talking about, because of the very specific organ in consideration, but note that it's basically the same thing. The goal is to restore insulin sensitivity, okay? That's by a combination of pulling out the excess fuel, as in fat, and by reducing the load in the system, as in how much you're intaking, whether it's because you're eating too much or burning too little, doesn't matter for now. You're trying to restore insulin sensitivity. Part 2 is you're going to protect the liver from the inflammation of the process itself. That second clause is why I'm going to recommend the next 2 things. If not for that clause, any old diet that'll help you lose weight is fair game, but because we have this inflammatory component, I got to be a little bit more careful. So, first clause, restore insulin sensitivity. Here are some ways you can do that. You can restrict the carbs, you can restrict the calories, you can do some moderate intensity cardiovascular activity, and truth be told, there are some meds that are useful for it. GLP-1s, SGLT2 inhibitors are excellent trade-off. They are not approved. This is an off-label use. And who knows how much Trulicity costs? Say it? Yeah. Somewhere in that zone. I'm hearing 1,000, 2,000. Can I get a 3? No, it's about somewhere in that zone, about $1,000. If you have a good RX coupon, I can get it down to about $780. That's a lot of money for an off-label use. So if they happen to be lucky enough to have diabetes, congratulations, 2 birds, 1 stone. But if they don't got that, what are you going to give them? As far as protecting the liver from the inflammation, we have different tools. Vitamin E turns out is useful. Same thing with TZDs. That's your pioglitazones. Trade-off is heart failure scary. There's also statins. Now, for all the whatever they do for inflammation, they actually do seem to help with liver things, so congratulations there. Omega-3s to help deplete the triglyceride load inside the liver, and then you have high-intensity cardiovascular exercise. Notice that moderate goes into one category, high-intensity goes into a second. It's because it turns out different ways of exercising do different things. That's kind of cool, actually. I didn't fully appreciate that until I started thinking of, well, yeah, I get strong when I weightlift, and I get good heart stuff when I run. But yeah, that's what this means. The idea is to fix this situation before they get deep into NASH, formerly recognized as F2 or above. One more time. If you get past F2, please call a friend. Unless you're the hepatologist in this group, then hey, we're calling you if they're F2 or above. The treatment plan collapses into basically the following. You're going to medicate the various aspects of metabolic syndrome. That's really what this algorithm says. It's if they have diabetes, treat the diabetes. If they have hypertension, treat the hypertension. If they have dyslipidemia, give them a statin. And by the way, if their lifestyle is messing this up, address that. If you look at the bottom 4 boxes, boxes 2, 3, 4 are to control the symptoms. Box 1 is to fix the problem. So we're going to focus on thing 1. I want to bring some attention to this idea. You guys remember I mentioned meat a couple slides ago and Kupffer cells. It's going to start coming together now. Something I want you guys to be aware of is part of why I like the carb restriction idea and the fasting idea for this problem is because it induces this state called nutritional ketosis. Now, is anybody here not familiar with ketosis either at a very low level or clinically? Is anybody new to this discussion? It's okay. I just want to make sure. Don't leave nobody behind. Independent of the reductions in glucose, independent of the change in pancreatic secretion of insulin, it turns out ketones are a powerful anti-inflammatory signal. That's important for this discussion. Because when you combine the fuel deprivation of a fast, or of a carb restriction, or a calorie restriction even, right, with the anti-inflammatory benefit of the ketosis itself, the compounded effect seems to be productive. I'll get into some of the data for that in a couple slides, but turns out it means something. And the question is, how do you get into nutritional ketosis? There's really two ways. Way one is something called a keto diet. It's basically low carb, low protein, high fat. If your cardiovascular situation can handle that, short term, rock on. But if it can't, play cautiously. The other way, a little bit more conservative, what I tend to use clinically is the fasting route, where you just tell them not to eat for a minute, because you know they have enough fuel in storage, because they wouldn't have that problem if they didn't have this disease state. So you say, hey, don't eat for a minute, have some water, tea, coffee, whatever, so you stay pleasant with your unfed. But the idea is by spending a prolonged time unfed or without carbohydrate, you induce this state of ketosis. The ketone bodies help with the process of healing the liver in this context. I want to drive that point in because if not for the liver, let's say metabolic disease without the NAFLD, I wouldn't be so specific onto that specific diet plan. You can kind of do whatever you want as long as it works. The ketogenic diet. For a standard American male, it's going to be about carbs below 20 to 50 grams per day. Protein is going to be 0.8 to 1.2 grams per kg. The calories are variable depending on if you want to lose weight or maintain weight. Some folks don't want to lose weight while they do this. Give me somebody whose BMI is like 22 or whatever, but they have NAFLD. Do you really want them cutting? Does that make sense? Cutting weight, I should clarify. So you might eat to maintain mass, but the type of food you eat is calibrated to deprive the liver of the thing it needs to get sick. To keep it simple for my patients, I tend to say something like, just don't think about it too much, just eat meat and leaves. And then I look at them, I pause for a second and go, actually, you know what? Make it leaves and meat. I flip the equation, I say meat and leaves because we're in Texas, and then I flip it just to get their attention and say leaves and meat instead. Add some turmeric or something. There are herbs and spices, there are actual nutraceutical things that can assist with this process. I save that for a phase 2 conversation while they build the habit. That's something I learned from that one. The diet has been demonstrated to show large improvements in ALT and AST, both of them, which is nice. Liver fat regression in 21 point whatever % of patients with overall reduction in it pulls out the fat. It pulls out the fat. The really weird thing is it seemed superior to the low fat, high carb, specifically in terms of liver pathology. That's a very limited statement. I'm not telling you that this is better than the whole food plant-based thing by any means. But for this specific disease process, it seems to perform superior, at least in the short term. Long-term consequences, don't know. We don't have the data yet, but it's worth investigating. Like I said, the other option is to fast. Now, the fasting option is what I prefer because it's a bit less controversial, it's a bit safer, in all seriousness, right? Because I don't have to worry about the food load as much. It's just making sure that they're fed when they're fed, and they can handle the time spent unfed, okay? We'll leverage something like water, green tea, coffee, whatever, as long as it's unsweetened, nothing added to it, you know what I mean? To give the body some caffeine so that you feel a bit better as you're depriving of energy. Because let's be real, most folks don't feel good not eating. They call it being hangry. You can mitigate the hangry with caffeine and salt, by the way. Just saying that from experience. Same thing, the time-restricted eating strategies have been shown to improve the ALT and AST. Here's where this one shines, and it outshines even the keto thing. The fasting thing, more so than the keto thing, seems to improve the fibrosis itself, which is really cool. And for those who do any sort of research or work in the intermittent fasting space, the thing to be aware of is when you go for about 2-3 days without food, if ever you try that, it triggers a lot of autophagy. Autophagy being this idea of cellular recycling. You eat a bunch of stuff in your body that doesn't belong there. So when you have a bunch of not functioning hepatocytes and proteins and gunk and whatnot, and you don't eat for a minute, you start trying to eat yourself to maintain energy, right? You lose some lean body mass, and in that context, that's a good thing because you're cannibalizing the proteins that you don't need. And I like that for a disease where you have too much proteins that you don't need. Is this making sense? Cool, moving on. The question then is there any superiority to one or the other, to fatten or to fast? Keto versus the fasting strategies. And when they were put up against standard of care, I'll describe all three arms of the study in a minute. It looks like both the keto and the fast did reasonably well, honestly. The fast did a little bit better for, again, fibrosis, but as far as reduction of liver volume, kind of like what the bariatric guy was lecturing a while ago, as far as compliance, both were pretty equivocal. The standard of care diet did help. It did make a difference, but the effect size was not as big. What was standard of care? It was the calorie restriction with a reduction of saturated fat was the specific approach for that arm. By the way, for those who are getting this PowerPoint, all of these green hyperlinks link to the papers I'm using, so my references are kind of interactive. Cool. Now let's get to the exercise arm with the time, with the 10 minutes I got. Perfect. Oh, got it. So I paced for 5, my bad. I can slow down a second. Breathe. This is me uncaffeinated, guys. Can you imagine me with espresso? It's like a monster. Anyway, so as far as exercise, and this actually goes to my lecture for tomorrow, by the way. So there are 3 interventions that were studied in detail for the sake of liver health and physical activity. We looked at resistance training, deadlifts and all that stuff, deadlifts, squats, leg machines and all those things. We looked at moderate intensity continuous training. That's a really fancy way of saying distance running or distance cycling. You know what I mean? It's the, I'm going to do this at a steady exertion for 40 minutes type of stuff. And then the last one was high intensity aerobic training, closer to the CrossFit Tabata looking stuff. All 3 have something to offer. All 3 are worthy of consideration. They do different things, so you should know how they work differently. Sounds kind of obvious, but I want to tease that out. Resistance training, HIIT versus moderate continuous. That's the 3 arms, okay? For those who have access to look at the slides, what I did for any of the readers, I actually detailed what the training arms looked like. Because I can say resistance training and it's dumbbells, bicep curls. And for those who lift meaningfully, y'all know that ain't the same thing as doing deadlifts, right? Looking at one of my guys right over there. Thank you for the thumbs up. So what this slide is, it's a reference really for you guys. It's what the training arms actually did in detail. Shameless plug. This is the lecture for tomorrow. It's a bunch of my colleagues and I training. Hooray. So what happened? We're going to look at 3 different graphs. I'm going to go closer to the laptop for this one. We have the dark bar is going to be the resistance training. The medium bar is going to be the high intensity, and the lightest bar is going to be moderate intensity. Okay? And if you look at hepatic fat, notice that physical activity dropped all of them pretty much the same. Yeah, there's some difference, right? But clinically speaking, who cares? It dropped by greater than 30. I'm happy. As far as intrahepatic fat, so we have hepatic fat versus intrahepatic fat. It looked like resistance training was particularly good at mobilizing intrahepatic fat. Good to know. As far as fibrosis for the liver, this is where I was surprised. It turned out that the liver arm, the resistance training arm did a little bit worse than the other 2 actually. So for all the benefit that weight training does for the sake of getting you strong, building muscle, sarcopenia, all that good stuff, if you already have fatty liver disease, it might piss it off a little bit, and that's worth noting. That being said, the high-intensity aerobic training, right, that's like the short bursts of extremely heavy activity followed by luxurious rest periods, seem to reduce the fibrosis. And I want to really emphasize that. It looks like HIIT training, okay, for those who are capable, was able to not just deplete the fat, but resolve some of the fibrosis. Remember, the NAFLD fibrosis score is calculated by your thrombocytopenia, your albumin, and your ALT, and by an ultrasound that kind of looks at how much fibrosis is actually in the dang thing. And that improved, and that's weird, unless you know what a Kupffer cell does. Hey, check it out, I put a slide about Kupffer cells. So what ends up happening is, let's focus on the middle bar, okay? Always looking at the middle bar right now. When you do a lot of HIIT-type training, what ends up happening is, you reduce the amounts of IL-6. That's one of the inflammatory cytokines going around. Same thing with TNF-alpha. You got to think about it like this. Training is a stress on the body, right? That doesn't mean it's bad. I like inflammation in that context, but it is an inflammatory load. And for a disease state where inflammation is the enemy, I might want to get strong without pissing my body off. So what ends up happening is HIIT training is heavy enough. It is sympathetic enough to cause you to mobilize your fuel, right? Think about all the epinephrine. Think about all the adrenaline it takes to deadlift heavy. One time, then rest, go for a run, come back, you know what I mean? But it's light enough in its volume that it doesn't piss off the system. You get a lot of sympathetic activation, a lot of energy mobilization right on the get-go, and then you recover. And that seems to be the magic sauce for this type of thing. TNF-alpha goes down, IL-6 goes down. Look at that Kupffer phase. Okay? Again, middle bar. You're activating your Kupffer cells, and that's a good thing in this context. You're auto-regulating them. in the context of what we're doing, this feeds into that autophagy system I talked about. When you activate the Kupffer cells in this anti-inflammatory environment, they start cleaning up the mess that is your busted, I'm not going to swear too much here, your busted liver. Cool. We're going to talk pharmacology a little bit, because the pharmacology is there. The issue is there's no FDA-approved drug. That doesn't mean that there's no drug. Those are different sentences, right? It turns out there are several agents that can help. And if your patient can get them approved, redacted, if you can get them approved and your patient can afford it, then rock on, put it to use. But if not, know that you can lean on the dietary stuff to get the work done, right? And then you can use these to leverage, to accelerate, to make it easier on them, to make it faster. But you don't have to rely on them, thankfully. GLP-1s, SGLT2s, biguanides, that's your metformin, coffee, which I'm lacking, and omega-3s, those can ameliorate the NASH itself. That can calm down the inflammation, as in your inflammatory scores, your CRP, your ESR, your ALT will all go down. The fibrosis will remain the same, as in the loss of functional tissue persists, but the heat burning you is gone. TZDs, aspirin, statins, vitamin E, and your ACEs and ARBs, they can improve or prevent the development of fibrosis, okay? As in, if you have NAFLD, you got NASH, you're high risk, give them the med, don't let them get fibrotic in the first place, keep them away from your hepatology friend, apologize. But it does not give you back what you lost. Does that make sense? So, one more time. You have your GLP-1s, SGLT2s, basically your diabetes meds plus coffee. Diabetes meds plus coffee will give you improvement in your lab scores. Your TZDs, aspirin, statins, vitamin E, ACEs and ARBs, basically your cardiovascular treatment arms, will give you prevention of fibrotic and inflammatory things. You put that together with some diet and exercise and you end up with, hey, your liver looks good. Sir?
So it's on aspirin.
When I was reading the paper here, they were looking at 81.
And favorite statin?
I honestly don't like any of them particularly over the other. Clinically speaking, I'll give them what I can get. Lipitor 10? I don't have a good reason to prefer one over the other for this specific discussion. Good, good, good. Yeah, if I think real carefully, where is it? This, I got you right here, man. When you get the PowerPoint for this, that green link will break down all of that with the actual drugs they use for the trial. So you can kind of follow it along. I think it was pravastatin for that particular paper. But when I look at statins as their own population, it was kind of ubiquitous across the whole thing. It was like they help as a class. Good. Anything else? Just checking. All right, so that's the pharmacology. And then you put it all together, so what do you got? Liver disease sucks. You can prevent it. You can treat it. It's a fascinating time to practice being an osteopath because it's something where we have to go holistic. We have to put together behavior, diet, exercise, and pharmacology to do something right for these folks. You know what I mean? It's a fun one for my family docs to take care of, myself included, because we get to use our ultrasound skills. You know what I mean? So it's a fun one to treat. And let's be real, it makes a difference. We can cut heart attack risk by half by getting this resolved. So what do? If you have elevations in your liver enzymes, that's north of 30, right? More or less, north of 30. But the ALT is greater than the AST, and you have fat in the liver using whatever modality you have access to, you treat them on the lifestyle side, that's diet and exercise, and then you support them with the pharmacology. On the diet side, for the sake of preventing this, rock on, use whatever diet works. But if you had one shot, one opportunity, Slim Shady M&M stuff, right? You use the thing that is most anti-inflammatory. It's kind of up for grabs if it's going to be keto versus the fasting thing. And honestly, the plant-based whole food guys have a good run for the money too. But I have only seen the literature for the fibrosis coming from the fasting arms more so than the others, which is why I favor on that. But realistically speaking, if these two are unfeasible for your patient, use whatever the hell you can. Because standard of care showed some improvement, right? And improvement is not the same as no effect, so you use whatever the hell they'll take. But if you got to optimize, now you know what to chase. Good deal. How are we doing? I got time for questions. This is a picture from a movie called Howl's Moving Castle. I like to use a bunch of Ghibli films to end things because I talk a lot and very fast-like, and he's very calming. Sir?
Yeah, the ACC/AHA guidelines
Yes.
say moderate to high-intensity statins. Does that have any impact on treating fatty liver disease, the intensity of the stat there?
Sort of. So I saw a little bit of back and forth between the cardiology and the hepatology sides of the conversation. We know that statins will sometimes transiently elevate the ALT and AST, right? Cause some liver damage. But at the same time, it's like, if the liver is already inflamed, what do you do? I admit I don't know the full answer, even clinically speaking, so what I do is I hedge my bet. So like, I'll go with the moderate intensity and hope for the best. And if the liver enzymes don't improve, I'll renege to lowering it or pulling a different maneuver altogether. Does that make sense? Cool.
Any benefit to elastography?
Yes. So I might have curtailed this a little bit because I assumed everybody here has ultrasounds. When I said order a liver ultrasound, I was talking about something called elastography. So you can order a right upper quadrant first to screen for the thing, but if you want to get the fibrosis score, the way you get that F0, 1, 2, 3, 4 is actually what, so what is your name?
Ron.
What Ron mentioned. It is a liver elastography is the order. Good.
Any benefit to any other nutritional supplements like milk thistle?
I've seen, so that's a game I was learning after I gave the lecture the first time. Some of my colleagues who are here, I'm pointing at it right now, educated me a bit about the use of milk thistle and turmeric. I know there's something to be said about them. It's something I don't dive into too deeply because I'm still learning it myself, but I've learned to at least leverage those two specifically. Sir?
A new GLP-1 is coming out, and we're all going to be hearing about that pretty soon.
You talking about Tripazidine?
It's being marketed, as another Me Too, but the aspect of it, the research is coming down in which it's looking like there's up to 25% body weight reduction, and it's also going to be treated NASH and other conditions because of its aggressive, much more aggressive ability.
Yeah, I've been looking at that with a close eye. If I can get that for my patients, I will leverage it aggressively. Yeah. You are talking about Tripazidine, right? Or Tripazid, something with a T. Yeah, it's, I know about it. I will one day know the brand name of it. Good. Any other questions? Sir?
Is there any benefit?
Wait for the...
We want to make sure the viewers from home can hear.
Yes.
Otherwise it's dead.
Yeah. And then we have her after that.
Any benefit to adding orlistat to that?
It's a weird one. So orlistat basically works as a malabsorptive, right? So what it would do is it would make you dump whatever you ate. Technically speaking, the benefit would be the energy deprivation. So if you were going to pair that with, let's say you did a more traditional diet, we'll say minimally processed food, good quality carbohydrates, the whole nine, you know what I mean? I can imagine orlistat being productive. At the same time, if I'm going to pair it with something like a ketogenic approach, that might be murderous. Yeah, because you're gonna poop all that out, man. But I will say situationally useful. If it helps with the diet compliance, if anything. Fair? Excellent.
One comment, one question. I'm here in Dallas, and it's impossible to find elastography unless you actually refer them into a GI office, which is very frustrating since we don't often need to send straight to GI. But second, you kind of alluded to this with one of your studies. I have a patient with NASH that has done all the things with lifestyle and has actually had good reversal. We actually saw shrinking of his liver, so some reversal of that hepatomegaly on his latest sono.
Nice.
I was told by his GI that this is not an indication that he's actually reversing his fatty liver, and concerned that it could be progression versus it's just an incidental finding. But would you disagree with that, knowing that he's done all the right things? Like, I have no reason to think that he's progressed.
It depends on that F score. So the elastography or your ability to ultrasound makes a difference in this conversation. If the liver is shrinking because it's progressing to cirrhosis, that is a problem. But if that shrinkage is absent cirrhosis and the liver fib went down, then we know it's the version that we're hoping for.
So you have seen an actual improvement in the liver itself?
Yeah.
Okay.
Yeah, we've had several patients demonstrate both ends. Like, I've had end-stage cirrhosis guys where I'm like, look, man, this looks great, and now they're decompensating because we caught them too late. I've had several more do the thing where the liver did shrink in size, and by standard measures that everybody will approve of, they showed reversal of disease. Do you have another one? Okay. Anybody else? Cool. These are really cool questions, y'all. I appreciate the guy who threw out the ACCHA stuff. I had to read that I trained for this, by the way. Like, I have to read all this stuff to speak here. So, like, I like these questions. I kind of come here, like, half looking for a fight. Not an actual fight, but, like, you know. You want to be challenged when you speak up here. It keeps it fun. All right, if there's nothing else, I'm going to step down. I'll see y'all tomorrow when I do my strength training thing.